Morning, students. Today we'll study urinary bladder. In my last class, I taught you ureters. So the ureters convey the urine from the kidney to the urinary bladder. So what is a bladder? Urinary bladder is the temporary storehouse of urine which gets emptied through the urethra. Alright, so all the urine which is formed in the kidney, it comes through the ureters in the urinary bladder, and from the urinary bladder they go out all the urine goes out from the bladder through the urethra. Now what is a urinary bladder? You all know, have come to know what is urinary bladder. Now the external features of the urinary bladder. What are the external features of the urinary bladder? The urinary bladder is a muscular reservoir of urine. It is a muscular bag, you can say, and its contractions help in the release of the urine, which lies in the anterior part of the pelvic cavity and is adapted for mass contraction rather than peristalsis. So I taught you last time that peristalsis occurs in the ureters, so that the urine can flow downwards into the bladder, and in the bladder massive contraction occurs so that the urine can just pass out through the urethra. So the external features are: an empty bladder is tetrahedral in shape. You all know what is this particular shape, and it has an apex. You can see in the diagram it has an apex. You also open your books while you are studying this topic. So it has an apex which is directed forward. You can see just now we are talking about the empty bladder. The base or the fundus, you can see there's a base. It is also known as the fundus, which is directed backwards. A neck, which is the lowest and the most fixed part of the bladder. You can see the neck is there, which is the fixed part, and it has three surfaces. Three surfaces are: first of all, it has superior surface. Which is the superior surface? You can see the apex and you can see the posterior border in the diagram. The area in between the apex and the posterior border is the superior surface. It has right and the left inferior lateral surfaces. The right and the left inferior lateral surfaces are not shown in this diagram. I'll show you later. And four borders: two lateral borders. You can see the lateral border in the diagram. Two lateral borders. One anterior border. You can see the anterior border, and one posterior border. Then the relations. Next, actually this was the features of the empty bladder. Now if the bladder is full, the urine is present there, so it is ovoid in shape. The superior surface just extends upwards like a balloon. So it has an apex, the apex directed upwards towards the umbilicus. In the empty bladder, the apex was directed forwards, but when the bladder becomes full, it is extended upwards. It directs upwards towards the umbilicus. A neck which is directed downwards, and the two surfaces, anterior and posterior. In an empty bladder there were three surfaces, but now two surfaces are there in the full bladder, that is anterior and posterior surfaces. Then the relations. What are the relations of this particular bladder with the different structures? So the apex is connected to the umbilicus by the median umbilical ligament. And the apex, you can see the apex and you can see the median umbilical ligament. Now what is median umbilical ligament? It is the obliterated embryonic urachus. There is a particular structure in the embryonic life, and this median umbilical ligament is the obliterated urachus. The base in the females. Now the bladder has, like the ureter, it had different relations in male and females. In the same way, the bladder also has different relations in the male and females, because it is present in the pelvic cavity, and the pelvic cavity contains different structures in males and in females. So in the females, it is related to the uterine cervix and the vagina. The base, The base is related to the uterine cervix and the vagina. I'll show you in the diagram later. Don't worry about the relations. In the males, the upper part of the base is separated from the rectum by the rectovesical pouch, and the lower part is related to the seminal vesicles and the termination of the vas deferens. The neck, now the relations of the neck is also situated in the base. So the neck is the lowest and the most fixed part of the bladder, and it is pierced by the internal urethral orifice. The base, inside the base there is the internal urethral orifice, as you can see in the diagram. In males, the smooth muscle bundle surrounds the bladder neck and the pre-prostatic urethra. There are small muscle bundles which are situated in this particular area for the contraction and other contraction purpose. In females, the neck is related to the pelvic fascia. Now, what is pelvic fascia? The pelvic fascia, it extends and covers the organs situated in the pelvis of the females. The neck is done. Then comes the superior surface. In males, it is completely covered by the peritoneum and is in contact with the sigmoid colon and the coils of the terminal ileum. In the peritoneum, when sir told you about the peritoneum, there was a diagram. I'll show you later. You'll understand that how it is related to the peritoneum and the sigmoid colon and the terminal ileum. Then in females, the peritoneum covers the greater part of the superior surface. So the superior surface is covered with the peritoneum completely. The peritoneum forms the superior surface. From the superior surface is reflected back to the isthmus of the uterus to form the vesico-uterine pouch. This was also in the peritoneum. The peritoneum, as it covers the bladder, it folds and it reflects backwards and it forms a pouch which is known as the vesico-uterine pouch. Then the inferior lateral surfaces. In the males, each surface is related to the pubis. What is pubis? The bone, pubic bone, which you might have studied in the hip bone. The puboprostatic ligament, the retropubic fat, the levator ani and the obturator internus muscles. I'll show you in the diagram what are these things. In the females, the relations are same except the puboprostatic ligament are replaced by the pubovesical ligament. Now, prostrate gland is only in the males. So, in the females, so puboprostatic ligament is replaced by the pubovesical ligament because prostrate is not present in the females. And you can see the posterior view of the urinary bladder. In the males, you can see this is the posterior view, the back portion of the bladder in the males. It is related to the, you can see the prostrate is there, the ejaculatory ducts are there, the seminal vesicles are there, ductus deferens is there. So all these structures are on the posterior side of the bladder in the males. Now comes the ligaments of the bladder. Now the bladder is present in the pelvic cavity and it is attached, or you can say it is located in its particular place by some ligaments which attaches it to the pelvic area so that it stays in its position. So these ligaments are the true ligaments. What are the true ligaments? The true ligaments are formed by the pelvic fascia. What are the false ligaments? The false ligaments are just the folds of the peritoneum. So the true ligaments are the lateral true ligament. You can see the lateral true ligament. You can see what are the lateral true ligaments. So you can see the lateral true ligaments of the bladder. They extend from the side of the bladder to the tendinous arch of the pelvic fascia. You can see the bladder, so it extends from the sides of the bladder to the tendinous arch. You can see this rounded portion to the tendinous arch of the pelvic fascia. So what is a tendinous arch? This is the thickened whitish band of fascia which gives origin to the muscles or the ligaments which are present in this pelvic cavity. It is a whitish band of the fascia which gives origin to the muscles which are present in the pelvic area. And the next is the lateral puboprostatic ligament. You can see the puboprostatic ligament. In the females, the puboprostatic ligament is replaced by the pubovesical ligament, as I told you before. So the puboprostatic ligament extends from the anterior end of the tendinous arch of the pelvic fascia to the upper part of the prostatic sheath. You can see it extends from the tendinous arch and it goes into the prostatic sheath. Next is the median puboprostatic ligament. The median puboprostatic ligament is not shown here. It extends from the back of the pubic bone to the prostatic sheath. So the two bones, the pubic bones, they join together to form the pubic symphysis. So it extends from the back of the pubic bone to the prostatic sheath. Then the next is in the females, you can see bands similar to the puboprostatic ligament are known as the pubovesical ligament, as I told you before. Then comes the median umbilical ligament. The median umbilical ligament, as I told you before, it connects the apex to the umbilicus and the posterior ligament of the bladder. It is directed backwards. It extends on each side of the base of the bladder to the wall of the pelvis. You can see in the diagram, it extends on each side from the base of the bladder, the base area of the bladder, to the walls of the pelvis. You can see in the diagram. The next comes the interior of the bladder. So these were the external features. Now if you see the internal structure, if we cut the bladder and we see inside of the bladder, in an empty bladder, the greater part of the mucosa shows irregular folds due to its loose attachment to the muscle coat. So the bladder is composed of the retrosal muscle and then there is the mucosa. So this mucosa is very loosely attached to the muscular coat. That's why there are some folds in this. These are irregular folds. So in this particular area, there are some irregular folds present. As you can see in the diagram, this interuretric, you can see this pink portion is known as the trigone. Above it, the area which you can see, there are some folds, and these folds are known as the irregular folds or rugae, you can say. Then in a small triangular area inside of the bladder, in a small triangular area, as I shown you in the diagram, mucosa is smooth due to its firm attachment to the muscular coat. In this particular area, this triangular area, you can see here this pink portion where the trigone is written in the diagram. This particular area is tightly attached. This part of the mucosa is tightly attached to the muscular area, and it is triangular in shape, and it can be seen differently. It can be seen particularly this triangular area. This is known as the trigone. This area is known as the trigone of the bladder. The internal urethral orifice opening into the urethra is located here. The ureter opens at the posterior lateral angle of the trigone. So in this trigone only, the ureters comes and gets attached. They open in this particular area. Then the capacity of the bladder, how much urine it can occupy at one particular time. So the mean capacity of the bladder in an adult male is 220 ml, varying from 120 to 320 ml. Filling up to 500 ml may be tolerated, but beyond this it becomes painful. So it becomes painful if the particular person does not micturate. So it can become painful after 500 ml. Then comes the arterial supply. So the main supply comes from the superior and the inferior vesical arteries. Now what are vesical arteries? These are the branches of the internal iliac artery. So what is internal iliac artery? As I told you, the aorta, it divides into two, common iliac arteries, and the common iliac arteries divides into the external and the internal iliac artery, and the internal iliac artery gives vesicle arteries. Additional supply is derived from the obturator and the inferior gluteal arteries, and in females the uterine and the vaginal arteries supply gives the additional supply. Venous drainage. There is a vesicle venous plexus which drains into the internal iliac veins. So all the venous blood, it drains into the internal iliac veins and from there into the inferior vena cava. Then the nerve supply. If you see the nerve supply of the bladder, so it is all muscular structure. It contains the detrusor muscle, and the internal sphincter mechanism is also present. Internal and external sphincter mechanism is also present in the bladder. So for its contraction and relaxation, these nerve supplies are very important. So the parasympathetic nerve supply is from S2, S3 and S4, and what they do, they are motor to the detrusor muscle and inhibitory to the sphincters. Then the sympathetic efferent fibers, they arise from T11 to L2 and they are motor to the prostatic sphincter. The somatic pudendal nerves S2 to S4 supplies the sphincter urethrae, which is voluntary and is situated within the wall of the urethra. Sensory nerves, pain sensations are caused by distension are carried mainly by the parasympathetic nerves. So what is this motor and motor to the detrusor muscle and all these things? Now sympathetic and parasympathetic nerve supply is different, it works differently. So the sympathetic stimulation in the urinary bladder will cause vasoconstriction. It will cause vasoconstriction and the internal sphincter of the bladder contracts to maintain the urinary continence. The internal sphincter, not the muscle, the internal sphincters which are present inside the bladder, it causes its contraction so that you can hold the urine continence can occur. And what would the parasympathetic supply would do? It inhibits the contraction of the internal sphincter of the bladder. It contracts the detrusor muscle of the bladder, which causes urination. So both the sympathetic and parasympathetic supply, they are working differently. One is causing continence and the other is causing the urination. So this is the urinary bladder. You can see the diagram very properly. The next comes the clinical anatomy. So the clinical anatomy, as you can see in your books, the bladder may be ruptured by injuries into the lower abdominal wall. So some injuries can cause the rupture of the bladder. Chronic obstruction to the outflow of the urine by an enlarged prostate or by stricture of the urethra causes hypertrophy of the bladder, leading to trabeculated bladder. So if the bladder is not able to get empty because of some causes, so this particular condition can occur. The interior of the bladder can be examined in the living by the cystoscopy. As you can see in the diagram, the cystoscope is entered through the penis in the males, and you can view the bladder. And urine incontinence, the next clinical picture which is there in the bladder is the urinary incontinence. Emptying of the bladder is essentially a reflex function involving the motor and the sensory pathway, and all these which I told you before. And if something goes wrong with the nerve supply and the muscles, etc., the nerve supplies to the muscle and the sphincters, so this normal emptying of the urine, contractions and all kind of stuff, relaxation can get hampered. So this was all about the urinary bladder. You just read it, and then if you don't understand anything, you can call me. All the things like the relations, etc., I'm gonna tell you again. I'll show you the pictures in the next video. Thank you.